Welcome to lecture number 2, arterial blood gas interpretation. So as the slide says, relax and just pay attention. It's really not that hard. It's really not that bad. All right. So acid-base balance is controlled by the concentration of hydrogen ions. The more hydrogen ions we have, the lower the potential for hydrogen, therefore meaning a lower pH. The more hydrogen ions the less hydrogen ions we have, means the higher the pH, because we have a higher potential for hydrogen. So that's what that goes back to. So the lower the pH, the more acidic something is, while the higher the pH is, the more alkalotic something is. So normal pH in the body is 7.35 to 7.45. You guys should already kind of know that. Anything less than 7.35 we consider to be acidotic when we're talking about the human body, and anything greater than 7.45 we call alkalotic in the body. True perfect pH in the body would be a 7.40. 7.40. If I say something has a pH of 7, what does that mean?
7.0.
And that is?
Acidotic.
If it's in the body. In terms of the whole world, 7 would be neutral. What is the only thing that has a pH of 7?
Water.
Pure water. Pure laboratory created water would have a pH of 7. So the normal acid to base ratio is 1 to 20. That means we have 1 part CO2 to 20 parts bicarb. And like we talked about in the last lecture, that's constantly changing. CO2 to bicarb, carbonic acid, bicarb back and forth, and vice versa. They're constantly changing. But realize for every one carbon dioxide molecule we have, we're going to have 20 bicarbonate molecules. Okay? Everybody understand that? It's a 1 to 20 ratio. So things that control pH. The first responders are bicarb, phosphate, protein, and ammonia. Those are our protein buffers. They're very limited in their capabilities of what they can actually do to manage pH, but they will start to, again, buff out those extra hydrogen ions. They'll either absorb the hydrogen ions in the event that we are acidotic, or they'll either emit hydrogen ions in the event that we're alkalotic, to try to bring our pH back into that 7.35 to 7.45 range. The second responder, the next quickest to react, is going to be the respiratory system, and it's going to control our concentration of hydrogen ions by the amount of CO2 that we blow off. Realize somebody that is acidotic is going to breathe faster because they're blowing off CO2, while somebody that is alkalotic is going to breathe slower because they're trying to retain or hold on to their CO2 to maintain their acid-base regulation. The third responder, and the slowest, taking up to 12 to 24 hours to respond, is our renal system. And it's going to increase or decrease our bicarbonate levels, either by urinating off bicarbonate or by holding on and retaining those bicarbonate and hydrogen ions. So those are going to be our principal things that we talk about when we talk about the regulation and control of acid balance in the body. So we talk about blood gas. Well, first of all, you're probably asking yourself, why do I need to know anything about blood gases? We don't do blood gases on the truck. Well, no, you may not do blood gases on the truck, but in the future, I'm sure you probably will. Second thing is you're going to take transfers out. And when you take transfers out and interfacility transfers, it's important that you understand these blood gases, because a blood gas can tell you a lot and a tremendous amount about the patient's overall airway status, as well as their overall metabolic processes. So normally ABG values that you need to learn is a pH, just normal like we talked about, is 7.35 to 7.45. CO2 is going to be 35 to 45 millimeters of mercury. Realize there's a correlation, if you can see that, between pH and CO2. Okay? But they are inversely proportionate, meaning if you've got a pH of 7.35, your CO2 is probably going to be closer to 45. And if you've got a pH of 7.45, your CO2 is going to probably be closer to 35, and vice versa. PaO2, or normal oxygen, is going to be 80 to 95 millimeters of mercury. O2 saturation is going to be 95 to 100%. And our base excess is going to be plus or minus 2, with a serum bicarbonate somewhere sitting around 24 milliequivalents per liter. Okay? And that is what we're looking at. So acidosis is anything with a pH less than 7.35. Can be respiratory or metabolic in nature. And we'll determine and discuss the difference between respiratory and metabolic here in just a few minutes. But realize that acid, whether it be in anaerobic or aerobic metabolism, primarily being aerobic metabolism, acid is going to be the end product. We're going to either produce carbon dioxide or we're going to produce anaerobic
Lactic acid.
lactic acid. That's right, lactic acid. So things that cause acidosis. Well, when we're talking about respiratory acidosis means something's probably wrong with the lungs. It's originating in the respiratory system. When we talk about metabolic acidosis, it means it's originating somewhere in the metabolic process. It could be an endocrine problem or numerous other things. Respiratory acidosis, things that cause that. Neurologic damage. Okay, somebody having a stroke. Somebody that's got a lesion on their brain. If it's causing them to breathe slowly, they're going to retain what?
Yep.
Which is going to cause them to become
Acidotic.
Okay? Somebody is breathing slow. They're going to retain CO2, which is going to cause them to become acidotic. If they've got an airway obstruction, like let's say we have a asthma patient that has a mucus plug and they're not able to exhale all of their air, they're going to retain CO2, which is going to make them acidotic. Same thing with a COPD patient. Metabolic acidosis, we have DKA, diabetic ketoacidosis. Ketones are acids, so we're emitting those, we're holding on to those. That's making us acidotic. Renal failure, if we're not able to excrete bicarb or the other hydrogen ions and other waste products, we're going to retain them and potentially become acidotic that way. Lactic acidosis from anaerobic metabolism. That is going to make us acidotic. And obviously, diarrhea, will make us become acidotic. Okay? Easy way to remember. If you have somebody that's got diarrhea, they're losing what? They're losing their base. Base out the bottom, acid out the top. So if you're vomiting, you're losing acid. If you've got diarrhea, you're losing base. So if you're losing a lot of base, it's going to make you acidotic. Okay? So that's the easy way to remember that.
What if you're doing both?
And it should all neutralize out and equalize out to a degree. You're probably doing one or the other more. Which one do you think you're doing more? Probably the diarrhea. You usually have more diarrhea than you do vomit, typically. So electrolytes. Electrolytes play into this equation as well, because potassium tends to go up with acidosis. Why would potassium levels rise in a patient that is acidotic? Well, if you've got a whole bunch of hydrogen ions floating around, hydrogen ions want to go somewhere. And hydrogen ions will start to go inside of the cell. As they go inside the cell, they're going to kick potassium out. So that's going to make us look like we have hyperkalemia. When in actuality, it's not that we're hyperkalemic, we're pseudo-hyperkalemic because we just have the potassium in the wrong area. If we start to correct the pH and the acid-base balance of the body, we're going to lose those hydrogen ions out of the cell, potassium is going to float back in, and now things are much better and start to equalize out. But realize, if we have high concentrations of hydrogen ions because we're acidotic, some of those hydrogen ions are going to hide into the cell, and it's going to pick potassium out. Okay? So, the opposite will happen in alkalosis. An alkalotic patient will have the exact opposite, rather than what we'll have is we'll have those potassium molecules moving in, trying to kick out any hydrogen ions that are in the cell out, so that way hopefully we can reduce the pH and make it lower. Does that make sense? Hopefully so. So, acidosis. When we talk about acidosis, we have compensatory mechanisms, just like with anything else in the body. The kidneys and lungs are both going to work to bring our acid-base levels back into normal range. Everything is going to be there to maintain that level of a 1 to 20 ratio. 1 part CO2 to 20 parts what?
Bicarb.
Bicarb. Okay? Just because the body fixes the problem does not mean we're out of the woods, though. That's important to remember. That's why we call it a compensated or a partially compensated problem. Okay? Because until we actually correct the actual problem and get everything into normal range, we've still got issues going on. Okay? But the body will do its best to compensate. Just like if you're in an area of low oxygen, what is your heart rate going to do?
Increase.
It's going to increase to circulate what oxygen you do have around faster. Okay? If your blood pressure drops, what's your heart rate going to do?
Increase.
It's going to increase too. It's compensation. It's the same thing when we're talking about acid-base balance. So acidosis. Respiratory acidosis, the kidneys are going to compensate by retaining bicarbonate to balance that acidosis. So if we're in a respiratory acidosis, that means we have retained too much CO2, so we're acidotic, so we're going to try to retain bicarb, because bicarb is going to do what to the CO2?
Buffer.
It's going to counteract it. It's going to buffer it. Okay? When we talk about metabolic acidosis, we have somebody that is acidotic because of a metabolic, like DKA. Patients that are in DKA, how do they breathe typically? Yeah, they're going to have small respirations, which are rapid and deep. Why do they have those rapid and deep respirations?
To blow off CO2.
To blow off CO2 to correct the acidosis. You following me with what I'm saying? So, on the other side of the coin, we have alkalosis. And alkalosis is defined as a pH above 7.45. Respiratory system, we have too little CO2. Okay? Give me an example.
Or too little CO2?
Yeah, what would cause somebody to be in respiratory alkalosis?
Would it not be narcotic overdose?
No, that typically causes acidosis.
HHNK?
No. How about hyperventilation? Somebody that's hyperventilating because they're blowing. That's right. That's why they have the carpal pedal spasm. Because they're blowing off too much CO2. Okay? They've blown off their CO2, which puts them in a state of alkalosis. Okay? Metabolic system, we have too much bicarb floating around. Okay? And not a whole lot of things that naturally cause that. But one thing, time when we see a respiratory alkalosis, or a metabolic alkalosis, think about the chest pain patient who's having chest pain all day long. Rather than calling an ambulance or going to the ER, they go to Sam's and they buy them the jumbo bottle of Tums. And they sit there and they eat that whole bottle of Tums before they call 911 or before they get presented in the ED. They're in a state of alkalosis because of all of the Tums that they've consumed. Okay, and that's just an example. So things that cause respiratory alkalosis, nervousness, or nervous syndrome problems, hyperventilation, and other CNS problems. Okay, lesions in the brain can also cause hyperventilation. Metabolic goes back to too much baking soda. Okay, so a lot of times we cause it as EMS providers or healthcare providers, and we give somebody bicarb or something else, or they self-medicated themselves. Gastric suctioning, somebody that's got an NG tube in, and we suck out too much stomach contents. When we're sucking out those stomach contents, we're pulling out acid, which is going to make them alkalotic because they've lost hydrogen ions. And obviously vomiting. Like I said, base out the bottom, acid out the top. So when we talk about alkalosis, the compensatory mechanisms for that, respiratory alkalosis, the kidneys will compensate by excreting more bicarb. We're going to excrete it, meaning we're going to urinate it out. We're going to get rid of it. The metabolic alkalosis, the lungs will retain more CO2. We're going to do our best to slow our breathing down. That's why when we're treating somebody that's suffering from hyperventilation syndrome, what do? We control and coach their breathing so that way they can hold on to and retain CO2, which will hopefully start to bring their pH back up into or back down into a more normal range. Okay. Remember a minute ago we talked about the oxyhemoglobin dissociation curve. Remember I said when we have somebody that is alkalotic, they're going to hold on to that oxygen and not release it. It's going to stay attached onto that hemoglobin. When I have somebody that's acidotic, on the other hand, what are they going to do?
Lose it too early.
They're going to lose it too early. They're not going to be able to maintain it and hold on to it. Okay? So decreased affinities are going to be caused by acute acidosis, high concentrations of CO2. Patients that have an increased temperature will also drop off the oxygen quickly. High levels of 2,3-DPG and abnormal hemoglobin. Increased affinity, holding on to it, acute alkalosis, decreased CO2 values, decreased temperature, low levels of 2,3-DPG, carboxyhemoglobin, methemoglobin, which we see in cyanide poisoning, and abnormal hemoglobin like in sickle cell anemia. Those will all cause increases in the sense that we don't release it like we should, or we hold on to it. Everybody follow me? You follow me? So things that are going to cause metabolic acidosis: DKA, diabetic ketoacidosis, lactic acidosis, renal failure, liver failure, severe diarrhea, okay, salicylate toxicity or aspirin overdose, and obviously starvation. If there's no food to consume, all that extra acid's floating around, it will cause us to become metabolically acidotic. So when we talk about this, we have a pH of less than 7.35, right? Because we're acidotic, so that means we're going to be less than 7.35. Our HCO3, which is our bicarb, is going to be less than 22. Okay? Because the more bicarb we have, the more alkalotic we are. The less bicarb we have, the more acidotic we are, right? Does that make sense? So, somebody that's got a metabolic acidosis is going to have a low pH, a low bicarb, and their CO2 levels may be normal or decreased for compensation. And we'll talk about compensation here in just a minute. But as the body corrects, think about it. This is metabolic. So anything that's metabolic in nature is going to be controlled by bicarb. Anything that's respiratory in nature is going to be controlled by CO2. Okay? So that's what we're talking about. If the CO2 answers the reason why they're acidotic or alkalotic, it means it's respiratory in nature. If the bicarbonate tells us that why they're acidotic or alkalotic, that tells us it is a metabolic problem. So that's how we classify whether it's respiratory or metabolic. Okay? Follow me? Okay? So, like I said, in a metabolic acidosis, the pH is going to be low, the bicarb is going to be low, and CO2 is either going to be normal, because nothing's happening, or it's going to try to compensate by decreasing the amount of CO2 we have, because we're acidotic. We don't need extra CO2, so let's blow it off. So we're going to decrease it as compensation. So what do you do for it? Well, IV bicarbonate may be indicated. You need to give them some bicarb to help along the process. Correct the cause. Figure out what's causing the metabolic acidosis. Fluids always will help you, because that'll help you to circulate, get things to the kidneys, get those extra hydrogen ions washed out. And just watch your monitor, because if they're acidotic, what's happening? Hydrogen ions are going into the cell and kicking what out?
Potassium.
And potassium causes
Increased contractility.
which will lead to arrhythmias. So we need to keep a close eye on our cardiac monitor when we have any electrolyte or any acid-base problem. We need to keep a close eye on our monitor. So metabolic alkalosis. So we just talked about acidosis. Okay. So alkalosis, they're going to have a high pH, right? Okay. They're going to have a high bicarb. Okay, and their CO2 is going to be normal, or it may increase. That makes sense? So, alkalosis means they have a high pH. So high pH, and if it's metabolic in nature, their bicarb is going to be high because that's what's causing them to be alkalotic to begin with. Okay, and the CO2 is either going to be normal, or it's going to increase to compensate, just like we talked about with the compensatory mechanisms. Things that cause metabolic alkalosis: suctioning. Again, suction out all their gastric contents are going to lead to a loss of excessive amounts of hydrogen ions. Excess alkali intake, taking too many Tums, Rolaids, or any other antacid. Adrenal diseases such as Addison's disease. Some of the others will cause metabolic alkalosis. Diuretic therapy. You're just losing too much hydrogen ions, so that's causing us to become alkalotic. Because realize that a lot of these diuretics don't spare. They just take whatever they can get a hold of and they're going to send them out the body. And like I said, base out the bottom, acid out the top. We're losing acid. Well, it's going to make us alkalotic. Okay? You with me so far? So what do you do for this? Well, stop the intake of bicarb for one. Once you stop that, that a lot of times will fix the problem. Because 9 times out of 10, the cause of this is going to be something we did. Maybe not something you personally did, but something in the healthcare team. Figure the underlying cause and treat for it. Again, watch your monitor, and if they are vomiting, consider giving them an antiemetic so they can hold on to it. What do you got for choices of antiemetics?
Phenergan or Zofran.
Phenergan, Zofran, and the others. All right, let's talk about respiratory acidosis. Okay, respiratory acidosis. If they're acidotic, they're going to have a low pH. So there we go. Their pH is less than 7.35. And like I said, if it's respiratory in nature, what's going to be the cause? CO2. So CO2 is going to be greater than 45 because that's high, right? Because normal CO2 is 35 to 45. We're greater than 45. So a low pH and a high CO2 indicates to us that it's respiratory acidosis. Bicarb may be normal if it's not compensating yet. However, if we do have compensation, it's going to be increased because we're going to see that the bicarb levels are going to rise to try to bring us into a normal pH value. That makes sense? The bicarb is going to try to counteract the CO2. Things that cause respiratory acidosis, CNS depression. Okay, anything that has to do with the nervous system causing the depression, increased resistance. When we're talking about ventilation, loss of lung service. If we have a V problem in terms of the VQ, if they don't have the surface area there to offload CO2, they're going to retain it and hold on to it. Neuromuscular disease, things such as myasthenia gravis, Gehrig's disease, whatever that can potentially have impact on the diaphragm will cause problems, and mechanical ventilation. We breathe for them too fast, and we're breathing for them too slow right now. And that's a very hard thing to try to tweak that ventilator and make sure that the ventilatory rate is appropriate. Okay, so that's respiratory acidosis. What do you do for it? Well, figure out what's causing the problem like always and fix it. If you fix the problem of what's causing it, you don't really have to worry about anything else because it's going to correct itself. If it's something that has to do with lung issues, bronchodilator, giving them some albuterol atropine, or considering giving them some epi or whatever to fix the problem, that's an issue. And again, looking at your vent settings, are you not breathing fast enough for the patient? That can be a problem for us. So respiratory alkalosis. So with respiratory alkalosis, obviously they're alkalotic, so they're going to have a high pH. Their CO2 is going to be low because they're alkalotic. Their bicarb is going to be normal or decreased because they're in alkalosis already. So they're going to stay the same, or they're going to drop off the amount of bicarb that they have. So what are things that are going to cause respiratory alkalosis? Hyperventilation syndrome, like we talked about, first and foremost. Fever. Fever will cause a respiratory alkalosis. Hypoxia, not hypoxia, hypoxia will cause respiratory alkalosis. Pain, obviously, because it's going to cause us to breathe faster. Same thing with fever. We're breathing faster, trying to blow off the heat. It leads up to that. Pulmonary disorders, CNS problems, and again, breathing too fast. We cause respiratory alkalosis very commonly because we have a tendency to ventilate our patients too fast. Believe me, we will work on that in the laboratory. Later on when we vomit till we puke. And yes, we actually do that. We bag until we puke. Obviously, vomiting till you puke would be exactly what you're doing. So I'm saying we bag until we puke. Okay? So what do you... Oh, yes.
You mean we're going to bag each other till we puke?
No, you're going to bag the dummy till you puke.
Oh, okay.
We puke or they puke?
Till you puke. You're going to be so sick of ventilating patients, you're going to puke. So, So what do? Well, figure out what the underlying cause is. Adjust your vent settings. That's the first and foremost thing. Or if you're hand ventilating the patient, slow down your breathing. Watch your monitor again, because we're going to have those electrolyte disturbances. Coach their breathing, and if there's a fever, treat the fever. Give them something to lower their temperature, so that way there's a decrease in metabolic demand. So, just like there's a systematic approach to interpreting an EKG or interpreting anything else that we have, same thing we're going to do with systematic classification of acid-base. Rule number 1, inspect the pH. Is it acid? Is it alkali? Or is it normal? Classify that. Once you make that ruling, it doesn't change. Okay, once you make the ruling, whether it's acidotic, alkalotic, or normal, that doesn't change. Then you're going to inspect the PaCO2. All right, and that's going to be your respiratory component. Because remember, I said if it's respiratory, carbon dioxide is going to be the controlling factor. If it's metabolic, bicarb is going to be the controlling factor. So look at it. So does your CO2 explain the pH? Then look at your bicarb. Does it explain the pH? One of them has to explain the pH. Then you're going to look for the compensation factor. And figure out, did the non-causative component respond appropriately? Okay, because it should be compensating for the problem at hand. Okay. With me so far? Okay. So the analysis of acid-base balance are easily determined using a series of systematic steps. Categorize the pH, like I said. If the pH is 7.45, it's alkalotic. If it's less than 7.35, it's acidotic. Once you figure out what the pH is, it never changes, and look for the component that causes the effect on the pH. So, have you ever watched the Maury Povich show? Okay, the Maury Povich show. What is Maury Povich known for doing? What kind of shows does Maury do?
It's not my baby.
It's not my baby. Who's the daddy? Okay, and that's what we do. When we're interpreting ABGs, we're being Maury Povich, because that's exactly what we're going to do. So we've determined whether it's acidic or whether it's alkalotic. Now it's time for us to determine who's the daddy. Okay? And we're going to figure out who the daddy is. If CO2 is the daddy, then we know it is a respiratory problem. If bicarb's the daddy, then we know it is a metabolic problem. So determine whether it's acidotic or alkalotic, and then determine who the daddy is. Is it CO2 that's causing the problem, or is it bicarb that's causing the problem? Okay. So if we have respiratory involvement, pH is going to be greater than 45 for acidosis. If it's alkalotic, it's going to be less than 35 in terms of CO2. Metabolic involvement, less than 22, we've got a metabolic acidosis. If we're greater than 26, we've got a metabolic alkalosis. And then we're going to determine compensation. Non-compensation, partial compensation, or full compensation. Okay? So non-compensation, partial compensation, or full compensation. Then we're going to turn to oxygenation status. If they're greater than 100 millimeters of mercury, it's called hyperoxemia. If it's 80 to 100, it's normal oxemia. If it's less than 80, it's mild hypoxemia. If it's less than 60, it's moderate hypoxemia. And if it's less than 40, it's severe hypoxemia. Okay? And that's what we're going to look at next. The slides did not come out like they were supposed to. But if you can see on the top line, we got non-compensated, middle line is partially compensated, and bottom line is fully compensated. So in a respiratory acidosis, our pH is going to be low. Our bicarb is going to be unchanged. Okay? And our PaCO2 should be what? CO2 should be high because it's a respiratory involvement. Okay? If it's partially compensated, our pH will be low, our CO2 level will be low, okay, our CO2 level will be high, and our bicarb level will be what?
Decrease.
Will be decreased or will it be increased? It should be increased, right? Because it's trying to compensate for that. So that's partially compensated. Now, here's where we get into what we classify as being fully compensated. If it's fully compensated, the pH will be in a normal range. It's 7.35 to 7.39. Notice it doesn't breach above 7.40 though, because if it breaches above 7.40, then it wouldn't be acidotic. Okay, but notice that that's on the acidotic side of normal. Because what did I say true normal was?
7.4.
7.4. So it's on the lower side, so that means it's acidotic. So fully compensated, they'll have a pH of 7.35 to 7.39. Their CO2 levels will be high, and their bicarb levels will be
Unchanged.
high, typically higher, because the CO2 or the bicarb is what's compensating for it. And so when we talk about respiratory alkalosis, our pH is going to be high. Our CO2 levels are going to be low because it's respiratory alkalosis. And our bicarb levels are going to be normal, unchanged. If it's partially compensated, our pH levels are still going to be high. Our CO2 levels are going to be low, and our bicarb level should be low because we're compensating for it. We're getting rid of it. You with me so far? Okay. If it's fully compensated, 7.41 to 7.45 because we're on the higher end. Our CO2 levels will be low still, and our bicarb levels will be low. But we brought our pH back into a normal range. Okay. Metabolic acidosis. Now we're talking about metabolic. So what's going to be the answer? Who's the daddy on metabolic?
Bicarb.
Bicarb is the daddy. So our pH, we're acidotic, so our pH is going to be low. Our CO2 level is going to be probably normal or unchanged. But our bicarb level, because we're acidotic, is going to be low. Okay? If we're partially compensated, our pH level is going to be low. Our CO2 level is going to be
low.
Is it going to be low or is it going to be high? It's going to be low. You're right. It's going to be low. Just checking to make sure you're awake. Okay? And our bicarb level is going to be low because we're acidotic. Okay? If we're fully compensated, our pH will be brought into a normal range of 7.35 to 7.39. Our CO2 level will be low, and our bicarb level is going to be low. Still following me? Okay. Anion gap. We're not going to spend a whole lot of time on anion gap right now, but just a little bit so you know. We've got cations and we've got anions. Cations are positively charged electrolytes. Anions are the negatively charged electrolytes. Cations that we have in our body: sodium, potassium, magnesium, calcium. Those are all cations. We've got some negative ions, which are anions, and that's chloride, bicarbonate. They have a negative charge. Most lab analyzers analyze the cations. They don't do a very good job of analyzing the anions. So what we're looking for is an anion gap. An anion gap is only going to be present in metabolic acidosis. And then we would classify it as being an anion gap acidosis. DKA, for instance, notorious for having an anion gap acidosis. So anion gap, normal sodium levels are 136 to 145. Chloride is 98 to 106. Bicarb is 22 to 26. And potassium is 3.5 and 5 to 5.0. Okay, it's usually excluded from the calculations. There you can see an anion gap calculation: sodium minus parentheses chloride plus bicarb, and that's going to give you what your normal is. A normal anion gap is 9 to 14 milliequivalents per liter. Here's the good news: you don't have to memorize that formula. The reason why you don't have to memorize that formula is because all labs pretty much give it to you already. They're going to have on the results sheet anion gap is, and you're looking for somewhere between 9 to 14. Okay? So calculating the anion gap helps to identify the occurrence and clarify the cause of the metabolic acidosis. What's causing it? Which electrolyte has been the culprit that's actually having the biggest degree of difficulty with this? An increased anion gap, or anything greater than 14, usually occurs when fixed acids are produced, like lactic acidosis, or added to the blood, resulting in a metabolic acidosis, which is going to be an anion gap acidosis. If we lose bicarb, it does not increase the anion gap, so therefore it would not be considered to be an anion gap acidosis. So again, when we see anion gap acidoses, it's going to be with like lactic acidosis, diabetic ketoacidosis, something in those lines. It's going to interfere with this. The way you're going to distinguish is that you're going to realize off the ABG interpretation that it is a metabolic acidosis. Then when you get the regular lab report back and you see that their anion gap is greater than 14, it's not only a metabolic acidosis, it is a
Lactic acidosis.
an anion gap acidosis. Okay. So here we can see in metabolic alkalosis, okay, non-compensated, pH is going to be what?
High.
High, because it's alkalosis. CO2 is going to be unchanged or normal because it is metabolic. Our bicarb, however, should be high because it's metabolic alkalosis. In partially compensated, pH is going to be high. CO2 is going to be high. And bicarb is going to be high. Fully compensated, we will have a pH of 7.41 to 7.45. We're going to have a CO2 level of,
It's going to be high.
it's going to be high, and our bicarb level is going to be
High.
So, to sum it all up, are we acidotic or are we alkalotic? Then, who's the daddy? Is it compensated? And then what's the oxygenation status? Clear? Everybody see that? You got that? Okay. Let's do another one. We got a pH of 7.59.
Alkalosis.
Alkalosis. All right. CO2 of 49. Does that explain alkalosis?
Yes.
49 CO2 explains alkalosis?
Not entirely.
No, that's going to be compensated.
Okay, so we're seeing some compensation already. Does the bicarb of 48.2 explain alkalosis?
Yeah.
Yes. That's a lot of bicarb. A lot of bicarb equals alkalosis. So we know we have a metabolic alkalosis. CO2 is high, so does it mean it's compensating?
It's compensated metabolic alkalosis.
Is it what kind of compensation though? Is it fully or partially? Partially, because our pH levels are not normal range. Okay, and our PO2 status is 58.7, so
Moderate hypoxemia.
so we have a
Compensated.
partially
compensated.
compensated metabolic
Alkalosis.
with moderate hypoxemia. A partially compensated metabolic alkalosis with moderate hypoxemia. Understand? Okay. Number 3, 7.17.
Acidosis.
Acidosis. Does the CO2 of 69.3 explain acidosis? Oh, yes it does. Does the bicarb of 21 explain acidosis?
No, but it looks like it's trying to compensate already.
21? That's low, huh?
It's not compensating at all.
22 to 26 is the range for bicarb, isn't it?
Yes, but it's out of 22. It's below 22. Does a CO? Okay, so let's look at this. 69.3 CO2. Does that explain acidosis?
Yes.
Yes. Does a low bicarb explain acidosis? Oh, it does. What the heck do we got going on here? Oh, who's the daddy? This ABG's been dirty, dirty, dirty little ABG. This pH has been naughty.
Since the bicarb's low, wouldn't it be metabolic?
Ah, but the CO2 explains. The bicarb explains this pH, and the CO2 explains this pH. What in the world could be going on here? Could both of them be the daddy?
No, I agree.
Could both of them be the daddy? This is going to be an interesting DNA test result here in just a few minutes when we get the results. Let's look at the oxygen status. All right. 40.9.
It's still just moderate hypoxemia.
Let's see what we got going on here. Are we ready for results? It's a combined metabolic and respiratory acidosis with moderate hypoxemia. That patient is jacked up, okay? Not only are they acidotic from retaining or whatever the problem is, this could be a COPD patient that's in DKA too, okay? They'll be jacked up. Make you think twice about being diabetic and smoking, won't it? So, let's go on to the next one. Got a pH of 7.45.
It's slightly alkalotic.
Okay, it's normal, but it's on the alkalotic side of things, so we're going to keep an eye. We've got an analyzing mind, so so we're going to call it alkalotic, but it's normal. Okay, CO2 27. Does that explain pH of 7.45? I think it does. The low CO2 would explain a high pH, wouldn't it? Yeah. Does bicarb at 19.1? Does that explain a high pH?
Yeah, the bicarb's a little low.
So who's the daddy on this one?
Acidosis.
Okay, so we got a pH. So we got a high pH, so we're alkalotic. Okay. Low CO2. Does that explain alkalosis?
No.
A low CO2 doesn't explain alkalosis?
Oh,
Yes, a low CO2 explains alkalosis. So this is a respiratory alkalosis. Bicarb normal is what?
22 to 26.
22 to 26. It's 19.1. It's low. So compensating?
Partial compensation?
Oh, not partial. Why is it not partial?
Because it's within the 7.45.
So we have a fully compensated respiratory alkalosis with
mild.
Yes.
Positive.
Yeah. It's a fully compensated respiratory alkalosis with mild hypoxemia. Clear? Makes sense?
Severe hypoxemia.
All right, let's go do another one here. pH 7.28.
Acidosis.
Acidosis. PCO2 79.5. That explains acidosis. That explains acidosis. So you got a respiratory acidosis. Bicarb at 37.1.
Partial compensation.
Yeah, it's a little engine that could. It's trying to compensate, man. It's trying to get up and rise as fast as it can. PO2 is 30.
That's severe hypoxemia.
So we have a
Partially
compensated
respiratory alkalosis. Acidosis.
partially compensated respiratory acidosis with severe hypoxemia. Let's do another one, shall we?
Acidosis.
pH 7.46.
Alkalotic.
Alkalotic. CO2 34. Does that explain alkalosis? Normal CO2 is 35 to 45?
It could.
It does. 30, that's less than 35, isn't it? So that means it's alkalosis.
Would that be full compensation?
What's the bicarb looking at?
It's normal. It's within
Oh,
unchanged.
it's normal. All right, so and the PO2 is,
Moderate hypoxemia.
so we have a,
Respiratory alkalosis. Let's see. It's not compensated.
so it's a non-compensated respiratory alkalosis
with moderate
hypoxemia. Follow that? You getting this? Just takes practice, guys. Takes practice. Believe me, you'll have homework on this.
Yeah.
pH 7.36.
Slightly. It's on the acidotic side of things.
So it's on the acidotic slide of normal. PCO2 of 30. That doesn't explain acidosis, does it?
Not with the bicarb of 15, though.
Bicarb 15, so we got a metabolic acidosis. Ah, it's CO2. Is that?
Would that be uncompensated?
No, it would be CO2 at 30, and CO2 is dropping off, isn't it? So do we have a
Partial compensation.
pH is normal?
Fully compensated.
Fully compensated.
Metabolic
Acidosis with normal oxygenation.
Okay.
Compensated metabolic acidosis with normal oxygenation. Shall we do one more?
Well, might as well.
pH 7.42.
It's on the alkalotic side.
Alkalotic side of normal.
Can be fully
CO2
compensated.
is. Does that explain that pH? No. Bicarb. Does that explain that pH? Huh. What the heck?
So full compensation.
Well, those are both in normal limits.
Huh. So what do you think this is?
An anion gap.
No. How about a normal ABG? Quit overanalyzing everything. There are such thing as normal blood gases. Okay, not every blood gas is going to be abnormal. Alright, that is ABG interpretation. Questions, comments, snide remarks, post them on the discussion board so your classmates benefit. Hopefully you've enjoyed this. We have one other lecture to do, capnography, which we'll follow up on for this week. So we'll see you in lecture number 3.